maybe let's just briefly chat about tomorrow, really exciting data for GI in the plenary section with Atomic being presented. So we're finally going to see data with chemotherapy and immunotherapy in the adjuvant setting. Long awaited trial. But lots of happening in the neoadjuvant setting too. And I think the tricky thing with Atomic is going to be, unfortunately, it was a little bit ahead of its time, and the comparator arm was with chemotherapy and IO. And
6 months.
And 6 months. And but we have niche with just a dose of Ipi and 2 of Neo. We have dostarlimab. And so how are people thinking about like rectal cancer and colon cancer? And let's actually start with colon, because I think it's a little more interesting. And then we can go on to rectal. Is anyone yet thinking about neoadjuvant immunotherapy for?
Oh, yeah.
Yeah. It's I mean, same. It's sort of becoming a little bit of my pet peeve to get MSI-High patients after surgery now.
Yeah, no, completely.
And it's and I think everyone is humbled by maybe the rare IO talks they have, but we hurt people sometimes with adjuvant therapy.
Right.
And I think pre-Atomic we had no data to support giving anything, and it used to really it was really hard to get a stage 3 patient that was MSI-High when you had all this neoadjuvant data. So are people kind of adopting niche, or are they doing more?
I have done a couple off protocol in the past, and with success, fortunately. So it was great experience, and they are NED.
And a lot of these are little old ladies, right?
Yeah, one was an old. Actually, 2 were older. Yes, that's right. And one was a gentleman with 2 different primary tumors, MSI-High patient, Lynch patient, and he's doing extremely well.
And I've been doing similarly, and it's almost like we're seeing a trend at Anderson, at least, of these, they're coming to surgeons first. They've been diagnosed with stage 2, 3, and the surgeons are like, hey, can you just take them over? And do I really even need to operate? And the answer is probably no, right? So we've definitely been adopting more of kind of a niche criterion there and trying it. And we do have clinical trials as well to really try to understand that more deeply, but certainly have been successful in doing so.
I think it really demonstrates the importance of the multi-D discussion, though, right, with our surgical colleagues in the colon cancer setting.
Yeah, we've been trying to adopt almost a workflow in Epic where they can check when they see the surgeon of, does MSI-High status back? And almost as a hard stop, so that at least they've because they're so busy, it's high volume and they're so busy, and so just as a little check, just call me, I don't, just give me a call. I'll be happy to talk anytime.
But I think you bring up one of the more complicated things, which is in rectal cancers we haven't talked about yet, but we're getting more comfortable with non-operative management, I think, in much so, not just in MSI, but also in MSS. But then you have a patient who has colon cancer, and now we're saying we're very comfortable giving neoadjuvant immunotherapy, but not as comfortable omitting surgery.
Right, yeah.
And this came up in my clinic recently with a patient with a sigmoid cancer, where technically you could actually probably survey more easily, but I was like, but the MRI isn't as good, and it's still, it's a less morbid surgery. So we really had a lot of circuitous discussions because patients want data faster than we can generate it. And I think we all know that there are patients that don't need surgery, but we also know that a clinical complete response is not the same as a path CR. And so it's so hard to know if we can skip.
I think that's important to keep in mind, based upon Miriam's data, that all those patients went on to surgery, right?
Exactly right.
So for the niche 2 and niche 3, so versus our rectal cancer patients, which they're thinking about sphincter preservation.
Exactly.
So I think it's really, really interesting, the duration of therapy, and whether or not we should proceed with surgery.
Yeah, and then rectal, I think wide scale adoption we've seen of non-operative management and dostarlimab. I think anecdotally we could all say we're certainly not all hitting Andrea's 100%.
Right, not quite there.
Yeah, hopefully we'll have that the trial results soon, validating
exactly. But looking quite good. Are there settings where, even in rectal cancer with the goal of neoadjuvant therapy, bulky disease, where you're choosing to do kind of Ipi-Nivo, doublet instead of monotherapy?
I did do it in a young patient, I have to agree.
I would probably do it in a young patient. I haven't had a young patient, but I would probably do that in a young.
Bulky, it was a bulky kind of tumor, not obstructing, but a bulky tumor with some adenopathy, so that's why I did that.
I wonder if it is going to be so much better. I mean, we don't think it's 100% in real world situations, but it is very good with single agent dostarlimab. So I don't know if it's needed to give some of the toxicity of ipi/nivo.
But what if you can get less duration?
Yeah, I mean, I think we just don't know. So I've been mostly doing single agent.
We had Kristen's study, as you know.
Oh yeah,
Yep.
exactly.
But before that, I did try a couple of patients off protocol while it was pending. But interesting. Looking
And
forward to
has
seeing
anyone like salvaged response where they've started with monotherapy and then you know, seeing like midway scans and things are progressing a little bit and you're like, oh, maybe I should add some ipi and.
Yeah, it hasn't come up, yeah.
I've done it once, but again, there's no real data, right? So yeah, it actually did. But
Did it work?
You have a case
it
report.
did. I should write a case
See,
report.
mine did
It
not
got me
work.
another year, actually. Not too much, but it didn't cure. But it did get us.
Are there, anything else that you're looking for 8HW data that would be helpful for your clinical decision making? We talked about duration and talked about toxicity a little bit.
There's, discussion about what does the first line data look like as opposed to kind of the
pooled analysis.
The pooled analysis. But, there was mostly first line patients. I personally feel comfortable on the data that's been presented, but I know that will be updated. There's some colleagues who that's their major concern is just wait till I see the first line.
Maybe you want to describe that for maybe the audience isn't aware since
Yeah,
it's
so
kind of
the 8HW, thank you. Yeah,
different
the
study design.
8HW was kind of capturing patients who are IO naive, but could be, didn't have to be first line exposure. Turned out most of the patients were, but the study was designed in a way that, and the data that we've seen is a kind of a pooled analysis across lines.
For the doublet versus the single, but for the control arm of the chemo arm, that was all treatment naive. Yeah.
I mean, I do appreciate that they did central confirmation of MSI status. As we know, in 177, that wasn't done. So for the pembrolizumab study, we don't actually know what % of patients. And I think it was, in some ways, shockingly low how many patients on 8HW had actually centrally confirmed MSI-High status. And so it really gets back to your earlier question of how do you test and are you testing correctly? And I think that doing IHC to get a rapid result makes a lot of sense, but probably we should be confirming with NGS, especially as that completely changes how we treat a patient.
Absolutely.
Yeah, and I think there's some data that's been reported on kind of what those non-centrally confirmed, like how many, and it is a bit of a mix. It looks like there really were some false MSIs that really were MSS at the end of the day that were in the data.
Right, and that's what I heard on the keynote, right? Yeah.
Yeah, and I think, hopefully GI oncology is like latecomers in the IO space, and so I know a lot of toxicity concerns, but particularly for a lot of the community oncologists, I think, they probably have had more IO experience than, us across their tumor types, and so I think we learn and we have multidisciplinary teams that help support us through the toxicity too, but I think a lot of good resources for IO management, and we have an immunotherapy toxicity now just team that has coalesced to help manage tox. I'm not sure how you guys find support for toxicity at your institutions, but.
Yeah, I think we're lucky that we have, our GI folks and our pulmonologists and our rheumatologists. And I think a lot of people have sort of, self-identified as within their specialty being interested in, when things go bad with immunotherapy. But I think it is harder in the community if you don't have that expertise because it's complicated sometimes. We'd love to think that steroids is going to fix it all, but we know it doesn't. And on those really intense times, you don't want to lose someone over toxicity.
Absolutely. Any other toxicity tips that you have for people at all?
No, I think the most important thing is that patients communicate with us as soon as possible at the first sign, and for as providers to not hesitate to address it immediately if you really believe it's IO related. Don't presume it's a URI or just some GI distress due to something that they ate.